question, and that's actually one that patients ask most often after they go through a very detailed, comprehensive surgical evaluation. They want to know at the end, how do we know if that surgery is going to work or not? And up until about 2015, that decision was made based on clinical judgment. We have looked as epilepsy specialists into data that has been accumulated over years with small series in different hospitals, giving us some signals as to what patient characteristics could highlight people that could benefit from surgery versus not. So, for example, we knew that people who had an abnormal spot in their brain on their MRI would be more likely to benefit from surgery. We also knew, for example, that patients who haven't had epilepsy for a very long time were more likely to benefit from surgery. So we were putting patients into these buckets where if you have this one category, you get a green mark. If you have this opposite one, you would get a red checkbox. But the challenge that we had as physicians is that patients don't really fall into neat boxes. As an individual patient, you could have one part of your epilepsy that puts you in a good outcome category. So for example, you could have an abnormal area on your MRI, which theoretically should be a good thing. If it's removed, you would do well. But then you also had epilepsy for a long time, which in and of itself would be a bad marker. And we would have to just guess, essentially, combining all of that information as to how we would predict. So that's why there was a need to develop something that is more systematic, that looks at large data sets, that incorporates all of these different characteristics that patients can have into a comprehensive measure, one that would account for all different characteristics that patients have and come up with a final assessment. In a way, putting in the good with the bad, how does it add up at the end? And that's why there was an interest in developing outcome prediction scores. So the Seizure Freedom Score was a score that we developed a couple of years back. It was our initial attempt at trying to address this challenge of having multiple factors that could affect outcomes and figure out a way to account for them. So we identified, based on our prior experience, we had been working and publishing in this field for since 2006, I would say. So we had identified the top 8-10 clinical characteristics that matter, and then we worked on them some more to simplify them further, and we ended up with 5 that seemed to matter the most. And we put them in a scoring system where if you take the example I just gave, say about the MRI abnormality, if it's there, you get a point. If it's not there, you get a 0. Same thing for how long they had seizures. Same thing for the other 3 characteristics that we looked at, which were all fairly straightforward. Then we added up. It was really a simple addition, and we looked to see how good would the performance of that addition, of that whole score be in categorizing patients into these outcome buckets. Very good outcomes, very poor outcomes, and then people in the middle. And we ended up finding that that score does predict very well people who are either you're the best case scenario or you're the worst case scenario. Then that Seizure Freedom Score performs very well. Its challenge was in how can we improve it to help us sort out better the people who are in the middle. And that's why the second step after the Seizure Freedom Score, we pivoted towards an individualized risk prediction model that was a bit more sophisticated, called a nomogram, which is a risk calculator. So it's essentially a website that you go to, you enter the individual characteristics of your patient. So you don't have to split them into long or short epilepsy duration. You don't have to make those assessments ahead of time. You just input how long they've had seizures for. And it gives then an outcome prediction that is for that specific one patient that you're interacting with. So there is no more buckets that we are forcing people to fall under. You know, in a way, the cookie cutter, we threw it away. The seizure freedom score gave us a big cookie cutter, a medium cookie cutter, and a small cookie cutter, but it was still forcing people to fit. That nomogram just took every cookie cutter out of the equation, and you were then designing that outcome assessment individually for each patient. It helps the patients get a better expectation of what's to come should they decide to have surgery. The whole idea of starting projects related to this individualized outcome prediction came to me actually from a patient. It was a patient who was seeing me in clinic and was considering temporal lobectomy, which is the most common type of surgery that we do. And she was asking me about her odds of being helped with that surgery. So I was giving her the numbers that we had at the time. I said, well, half the patients who get it are seizure-free 10 years, 15 years after surgery. She looked at me and she said, Dr. Jehi, I'm asking about me. What are my odds of this helping me? I don't want you giving me the numbers of everybody else who had it. I want to know if it's going to work for me or not. So it was that challenge that pushed me in that direction. And that's when we developed the seizure freedom score, and then from it that online risk calculator, which we are still continuing to improve and refine to make it more accurate. But patients want to know if whatever we're offering them is going to work for them. We try to compensate for that by telling them how well it works in general, but we're talking in this context about brain surgery for epilepsy. It's a huge commitment that a patient is making. So they deserve an individualized opinion and not a general statement.